continue to talk. We talked about the pulmonary function tests last time. So we're going to talk about some more pulmonary diagnostic testing. So I know you have varying backgrounds, but please stop me if to ask questions. Okay. So we're going to talk about an hour. And I gave a few months ago a whole talk on chest X-rays, but I don't know how many of you were there. But this is, if you look at a chest X-ray, if you're shadowing in an emergency room or working with a doctor, this is what you're going to see. As you're staring at it, okay, this is a posterior, what we call a PA view. So right is left is right and right is left, okay? And you'll get I don't even think of this as being left anymore. It's so this is a right lung. This is the lungs are paired. This is the right lung. It's all black. And that's air. That's what you should see. And the heart's in the middle. This big structure in the middle is the heart. So one heart, two lungs. What else can you see? You can see the ribs. You see the ribs? Okay. Yeah. And you can see the clavicle. There's a lot of things you can see, just pointing out some things. Okay, the shoulder joints, if we moved it over a little more, okay. You can see some stuff below. This is the diaphragm, and the abdominal structures are below here, okay. And so that's your basic chest X-ray. Here's the aorta, which is the main blood vessel in your body, kind of courses like this and then comes down. You have the ascending and descending aorta. Anybody have any questions about the chest X-ray?
No.
All right, what can you do? You can look for pneumonia. That's why I say if you're in an emergency room and you're following around the doctor or another healthcare professional, you can look for pneumonia. You can look at the heart size. You can look for fluid, either around the heart or around the lungs. You can look for a collapsed lung. You can look for tumors or nodules. Nodules are just smaller versions of tumors below 3 centimeters. You can look if you put a large IV in the patient's subclavian vein or in the internal jugular vein. You can look for the line placement. If the patient's in respiratory failure and you put a breathing tube in, like an endotracheal tube, you can see the placement of the tube. You can look for rib fractures. If somebody comes in with chest pain, you could look for rib fractures. But rib fractures, subtle rib fractures, may not be seen on a chest X-ray, and you may need what they call dedicated rib films to show. But you may see fractures on the chest X-ray without ordering rib films. And you look under the diaphragm. Air under the diaphragm means that you've perforated something, like you've perforated your intestine or your colon. Okay, and you can look for lymph nodes also in the on the chest X-ray. Okay.
I have a quick question.
Yeah, sure.
Is it difficult to discern a pneumothorax from a hemothorax on a chest X-ray?
A pneumothorax with a what, Greg?
From a hemothorax.
Hemothorax means blood. Greg, hemothorax means blood.
Right. But
so blood is fluid. So a hemothorax would come under hydrothorax. So it would be fluid. So by looking at the film, you would know there's some type of fluid around the lung, in the space around the lung. It could be water from heart failure. It could be blood, which would be hemothorax. It could be pus, which would be an empyema. Okay.
Okay.
But that's solid look. That's solid looking. A pneumothorax is air. So the lung collapses, and you see you just see darkness. Okay.
Okay.
There's a big difference. Okay. This is emphysema. Okay. And you can see the X-ray. If you remember the other X-ray, This is a big hyperinflated X-ray. The lungs are large. If I remember, I told you the last talk, any of you were there, that the lungs are one organ with it. If it's bigger, it's probably bad, because what happens is air gets in but can't get out on expiration, so the lungs become hyperinflated. You can see a big hyperinflated X-ray there. And the flattened diaphragms, because the lungs hyperinflate, the lungs get big and then they flatten down your diaphragms. They push down your diaphragms. Diaphragms should be curved. They should be coved. That's the best way to breathe. So your pressure volume curve becomes disadvantaged when they're pushed down like that. And the heart becomes kind of squished and tubular. This is not, from a rare disease. This is from smoking cigarettes, okay? And I'll show you on a lateral film, the retrosternal airspace. And no matter how good your chest X-ray is, your CAT scan is more sensitive, your CT scan. The retrosternal airspace is this area, okay? This is a lateral film. So this is a PA film, and this is a lateral. If you've ever gone for a chest X-ray, they put you in two positions, except sometimes in the emergency room, they'll do what's called a portable film, and they'll only do one view. And you lose, you're not advantaged just getting one view, you see more. But this is the retrosternal airspace. And if you're fortunate enough to get a CAT scan, you can see these big emphysematous airspaces. You can see very well on CAT scan that you wouldn't normally see on chest X-ray.
Wow.
Okay, any questions about that?
I mean, it's pretty striking.
Yeah.
So for this X-ray, I guess what is the discerning feature that it's emphysematous? Is it the darker consolidations, or is it kind of like the stringy like white?
No, the large lungs, the hyperinflation, and the flattened diaphragms.
Okay.
Okay, and the retrosternal airspace. The last X-ray I showed you was even bigger. Okay, but remember, it's a disease. My diseases are diseases of expiration mainly. Okay, so the air goes in. Okay, but when you breathe it out, remember those PFTs that we did a couple of weeks ago? The airways collapse. Okay, and the air gets trapped.
Yeah.
And you can see it on the X-ray, you can see it on the CT, and you can see it on the pulmonary function tests. Like, remember we talked about high residual volume and high total lung capacity. You can see it on the pulmonary function studies. This is all trapped air.
Wow.
Okay.
All right. And it's nice to be able to correlate the patient's symptoms, their physical examination, their X-ray, their CT, put it all together. I mean, that's what really makes clinical medicine, so much fun. Okay,
Wow.
It's not science. I mean, I know, Greg, you're a scientist, and it's not science, but it's.
I don't know if I'd call myself that.
I think you are. But it's it's just kind of a puzzle that you put together. But you just have to know what each piece of the puzzle represents.
Yeah.
Okay, this is a guy, let's say, who comes in the emergency room with fever. He woke up in the middle of the night with right-sided chest pain, fever of 102, and coughing. So what does he have? Okay, he's got pneumonia. You see this? You see all this stuff? This is normal. Remember, this is normal. This is all normal. The lung is black. The lung has air. Okay, but this is all consolidation in the lung. So under the right circumstances, 50-year-old man was feeling fine, woke up with right-sided chest pain, coughing, a fever of 102. A chest X-ray shows alveolar consolidation. all this fluffy stuff in the right lung. So he has right lower lobe pneumonia. And that's how you get, and you would start to treat him. So that's focal consolidation. We don't see that. Alveolar filling. Okay. And you may see not just one lobe. This is a lobar pneumonia, but, and this is consistent with a bacterial pneumonia. But some of the viral pneumonias, you know, you get diffuse, you get both lungs, and you get these, what we call interstitial infiltrates, kind of linear. Okay. All right. Now, here's somebody who comes, here's a 70-year-old with a history of hypertension and diabetes who wakes up in the middle of the night and can't breathe, feels better when they sits up. Okay. If he tries to lay down again, he can't breathe. Comes in the emergency room, short of breath. And this is what his x-ray looks like. Okay. His pulse ox, which we're always talking about, his pulse ox is low. Okay. And here we have all these interstitial infiltrates, these linear and nodular infiltrates, diffuse, bilateral, both lungs, very symmetrical, not like your other one where it was focal. So this patient has congestive heart failure. Okay. Could he have a viral pneumonia? Yeah, if he was a 20-year-old who had a cough and a fever, maybe this could be viral pneumonia. But with the story I gave you, this is congestive heart failure. This is somebody else whose heart is massive. Okay. So he may have heart disease. Okay. Or he may have fluid around the heart called a pericardial effusion. Okay, but this is a massive, massive heart. And this is just a one view chest x-ray. This is not anything fancy. My mother used to tell me you had to take Latin to become a doctor. I think there was one time in the history of medicine that you had to take Latin to become a doctor. Because doctors couldn't do anything. They could only say big words, you know. No, it's true. There were no, you know, prior to World War II, there weren't any antibiotics. There's an old, you know, if you were sick in 1492 or 1792, or, you know, you got about the same treatment. It's only in the late 19th century that surgery started, you know, with the Civil War in America. They started to do and document surgical procedures. And we didn't even have antibiotics, sulfa until World War I and penicillin until World War II. So made up a lot of big words.
I guess for the cardiomegaly, are there any remarkable like clinical serology markers that I guess could be predicted?
Well, you would first, you know, do an echo on this patient. You would do an echo and see how much fluid he had and see if he had fluid. Is this all heart? Or, I mean, I don't know. Is this all heart or is this heart plus fluid around the heart? So you'd want to know that. And you can do a point of care bedside echo, which will tell you that. And then you want to see what his vital signs are. Because if he's got fluid around the heart and low blood pressure, okay, then he's, you know, got cardiac, you know, what we call cardiac tamponade. You know, his heart can't push because they've got fluid around it. Okay. So then you would want to relieve the pressure around the heart so the patient could have a cardiac output. But you're going to want to
be cardiac shock.
I'm sorry.
Oh, sorry. You were. It was breaking up a little bit. I didn't know you were talking. That would be cardiac shock, right?
That would be shock. Yes. That would be hemodynamic shock. Yes.
Oh, okay.
Yeah, but you could relieve it, but it's because of compression around the heart. So you could relieve it by relieving the compression, not necessarily by giving a medication. This guy may have cardiogenic shock due to low cardiac output. Okay, so instead of his ejection fraction, which is his cardiac output being 60%, it's 20%. So he would benefit from drugs that would help squeeze the heart. They're called inotropes, and relieve the vascular resistance. Okay, they're called afterload reducers.
Does is hypotensive crisis always a feature of hemodynamic shock?
Well, it can be from a lot of different things.
Okay.
In other words, if you GI bleed and you bleed out, you know, two or three units of blood, you'll be in shock. But that's hypovolemic shock. That's from not enough blood.
Okay.
If you're out in the desert and you get lost, and somebody finds you before you die in 2 or 3 days, and you're severely dehydrated, you've got hypovolemic shock and you need fluid. Okay. If your heart fails and you're only pumping 20% instead of 60%, then you've got cardiogenic shock. So there's different types of shock.
Okay. Thank you for clarifying.
Okay.
Okay,
Good. Keep asking me questions. I know you're there. That's great. Okay. This is somebody who has a cavity on their X-ray. Again, nothing fancy. It's just a regular chest X-ray. They have a cavity. Okay. And you can see this circular thing with a hole in the middle. Okay. So a cavity in the top of the lung, we call it the apex, is very, very consistent with tuberculosis, okay? An upper lobe cavity. That's what we see in tuberculosis. And we see it in reactivation tuberculosis. So primary tuberculosis goes to the lower lobe, and you're usually asymptomatic. You don't know you have it. And then the organisms find their way to the upper lobe, where they stay dormant for years, months or years, and then it reactivates. And this is apical segment of the upper lobe here is where you see reactivation tuberculosis. But you could also see cavities could also be fungal. They could be cancer, another organism which mimics TB is nocardia, and Staphylococcus can also give you cavitary pneumonias or cavitary lesions in the lung. Okay, any question? Now, I could go on for 5 hours about chest X-rays, but I just wanted to give you a little taste. And we can redo the chest X-ray talk, you know, next year at some time. Next year is not far away. All right, just to give you a taste. I'm just trying to give you a taste of stuff. Okay.
Yeah.
All right. So sputum is something that we look at. All right. All right. So usually you cough sputum. Now there's a difference between sputum and spit. So normally we ask a patient to take a really deep cough and breath and get mucus from their lower airway. So we're not interested in just spit. Usually we're interested in stuff from the lower part of the lung, from sputum. Sometimes we do what's called an induced sputum, and we make them inhale hypertonic saline usually. Water actually can be very bronchospastic, but hypertonic saline, which helps them to cough and bring up mucus. So again, we're trying to get mucus from the lower airways. Let's say if we think somebody has TB, tuberculosis, and we put them in isolation, we want to get 2 or 3 sputums rather quickly so we can either diagnose them as TB or rule them out and get them out of the isolation. So, and if they're not bringing up mucus on their own, we're going to, this is a way of doing it, okay? If somebody is on a ventilator, let's say a COVID patient or any type of respiratory failure, and they have an endotracheal tube is a breathing tube. It's a tube that gets put into your windpipe if you can't breathe and hooks you up to a respirator. You can put a suction catheter through that tube and get mucus, or you can put a bronchoscope. I'll show you what a bronchoscope looks like in a few minutes. You can put a bronchoscope through the tube or through the patient's nose and get secretions from the lower airway. We call it a wash, which is just putting in some saline and suctioning it back, or a lavage where we put in large amounts of saline into one segment and bring it back to try to get a representative specimen of the lower airway.
As a quick question, why isn't isotonic saline used to induce a cough reflex? Why hypertonic? Or is hypertonic more?
Well, hypertonic is more causes more irritation. So in our cystic fibrosis patients, most of our CF patients get as part of their airway treatment, they get nebulizer treatments with hypertonic saline.
Oh, okay.
Along with inhaled bronchodilators. It's not only, it hydrates the airways, and it also it causes you to cough.
Okay, thank you.
Okay. So one of the things you can do in the sputum is to get a gram stain. That's initially, we had to, when we were residents, had a gram stain everybody's sputum. Nobody does that anymore for a couple of reasons, because nobody does what we did. But you know what Joint Commission is?
No.
Greg, do you know? Or
No, I don't know.
those are the people who go around and inspect you and give you a grade.
Oh,
So no hospitals can exist without a Joint Commission seal of approval. It's like the Good Housekeeping seal of approval.
oh, interesting.
So Joint Commission has said so we used to, in my old days, we used to gram stain the sputum. We had little labs on each floor of the hospital, and we used to stain our own sputums and look at the urines and look at our own blood smears, which was very, very time consuming, but very educational. So when we did rounds with the doctor the next morning, we not only had the history and the physical, we would tell him what we saw on all these different things. But Joint Commission said that if you're not a certified lab, you can't do this stuff. So, so we weren't all certified labs, so we couldn't do this stuff.
And they kind of did that with radiology too, right?
Well, we still look at our own X-rays, but we don't read them officially.
Okay.
Okay. I mean, now it's, again, we used to, I sound like I'm 100 years old, but we used to have to go to X-ray, 5, 6, 7 times a day to look at our patients' X-rays. But now every X-ray is on every computer, on every floor. So, we can continuously look at X-rays on rounds without leaving the nursing station. But we're not the official read. Sometimes I think my read's better than the radiologist, but we're not the official read of the X-ray. Okay, but we're still looking at them. I think unless you look at your, I had a medical student say that they were very angry because after being on my service, so every day, every patient, every X-ray was looked at by us. They said they were just on a service at another hospital, and all they did was look at X-ray reports. So, it's just part of, you get so much more appreciation if you see the patient, examine the patient, then look at their X-ray. I used to bring the nurses over to look at the X-ray too, because they were taking care of the patient, and I thought they would get a better appreciation of what they were seeing. All right. Again, so that's a basic thing we can do. So if you're looking at a sputum, so if you take the sputum from the patient, you go to your little lab and you stain it. So this is an inadequate stain. So what you're seeing here are gram-positive cocci. Okay, any of you guys had microbiology?
Yeah, a while ago.
Yeah, I mean, so these are gram-positive, and these may be little gram negatives here, these lightly staining ones, but you don't see any inflammatory cells. If you look over here, these flat things here are epithelial cells. So these are cells that line your mouth. Okay. So this is telling the technician that the sputum just is spit. Okay. So they're going to discard the sputum. All right. And there's a criteria if there's more than, you can't have any more than 10 epithelial cells in a high powered field. If you do, then it's an inadequate sputum. All right.
Okay.
Let me get this up. Okay. This is a good sputum. Okay. You see my pointer?
Yeah.
Okay. So this is a good sputum. So you don't see any epithelial. Maybe you see one epithelial cell. Okay. You see these cells which are polymorphonuclear leukocytes. They're polys. They're inflammatory cells. Okay. And then you see these purple staining so they're gram positive because they're purple staining, gram positive cocci, which kind of line up in pairs. 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. So what's a gram positive cocci in pairs? It's down here.
Oh, Streptococcus.
It's streptococcus. Yeah. So if it's in a chain, I don't know, it's streptococcus. It's some type of a streptococcus, like alpha strep. But if it's in pairs, then it's Streptococcus pneumoniae.
Yeah.
Okay. So you can look at this, again, your patient comes in with, that x-ray, consolidative x-ray, or they have a history of some other chronic lung disease and they have this gram stain. You can, you can treat them for pneumococcal pneumonia. Okay. And believe it or not, there's only about a 30% chance that pneumococcus will grow. Of course, it's a very fastidious organism, but by your history, your physical, your x-ray, and your gram stain, you could treat him for the pneumococcus. Okay. But this is a good looking gram stain. Any questions? So what you can do if you have rotations in the hospital, even though you're not allowed to go on the floor, you're not going to be able to stain these sputums on the floor or anything. You might request going to the micro lab and just going over some smears with the technician, especially if you're on an infectious disease rotation.
Is evidence of fibrosis apparent in recurrent pneumonia infections with that patient population?
Well, you can get scarring from a pneumonia, but that's not what, when we talk about pulmonary fibrosis or idiopathic pulmonary fibrosis, it's not from pneumonias.
Right.
You can get, so you have fibrosis, which is a general term, which means scarring. So you could get fibrosis in an area of prior pneumonia. But diffuse fibrosis, like idiopathic pulmonary fibrosis is another disease.
Right. Yeah, I was just curious if in patients who have recurrent pneumonia infections, if their lungs would be expected to be fibrotic. Oh, wait 1 second.
Not necessarily, but they could also get bronchiectasis. They could get destruction of their distal bronchi, which then dilate and then trap mucus.
Right. Okay. Thank you.
All right. Beside a regular gram stain, you could do an immunofluorescence. You can take an antibody and put an immunofluorescent stain in and see if it stains. You can do that for Legionella, although usually for Legionnaires, you normally get an antibody from the urine. Mycobacteria, which is where TB is a Mycobacterium tuberculosis. You do a special stain called a Zeal-Nelson stain. So it's not like a regular gram stain, which I just showed you. For a fungal, if you're looking for fungal infection, you can do what's called a KOH stain. Okay, here down here, you see where it is. This is a they call it a Schwartz-Lampkins stain, but it's a KOH stain for fungi, and this is pretty typical for Aspergillus. Okay, Aspergillus is a mold which lives in wet surfaces. It probably lives in your ceilings over the wet pipes. It's actually bread mold, and it becomes a very serious infection in patients whose systems are compromised, who are immune compromised. You can see these 45-degree branching angles here.
Mhm.
And if you see this, you're probably likely going to treat a patient, especially if you're immunocompromised. You're going to treat a patient for Aspergillus despite the culture. And with COVID, the sputum actually may be more sensitive than the nasopharyngeal swabs for detecting viral RNA. It's not clear, but in fact, the NBA, they do spit tests. I think they do daily testing in the end. When they were under the bubble anyway, they were doing daily testing in the NBA, and they were doing spit tests. Most of you, if you've gotten COVID tests, are getting the nasopharyngeal swabs, which is very uncomfortable. But in the early, especially if you're doing it every day, in early COVID, the viral load is very high in the mouth. So you could probably pick it up with spit. Later on, when the patient's very sick, it moves down into the lower respiratory tract, and you may not be able to get it from sampling the upper respiratory tract. Okay, but there's lots of things that can infect you, bacteria, fungi, mycobacteria, viruses. We have COVID now. We have flu now. Flu can also cause pneumonia.
Dr. Promisloff, my friend said that after she got COVID, her mouth was like bleeding a lot more than usual. And then you were just talking about how COVID's usually pretty high in the mouth. Do you think there's any correlation?
Well, she may have had a coagulation. The COVID causes a lot of issues with coagulation and clotting, and so she may have had that. It affects the blood vessels tremendously, much more than any other virus that we've dealt with.
Wow.
So she may have had a coagulopathy. Not the fact that it was in her mouth, but the fact that it probably maybe affected her clotting system.
Oh. Wow.
I hope she did okay.
Yeah, she's good.
Did you lose her taste or smell?
No. She was just bleeding from her gums a lot more.
Yeah. Her platelet count might have been low too. So again, one of the things that COVID does is it knocks down your platelets, and your platelets are responsible. One of the are responsible for your coagulation. This is a stain for AFB, TB, acid-fast bacilli means TB, tuberculosis. And again, it's a different kind of stain. It's called a Ziehl-Neelsen stain. And here, this is what TB looks like when the Ziehl-Neelsen stain. These little red things.
Yeah.
They're called red snappers. That's what they call them, red snappers.
Huh.
Okay. If you get that in the sputum, you're very happy because you've got a diagnosis. And again, you can put the patient, TB is treatable, thank God.
Yeah.
So you can treat them, and you can, after a certain amount of time, you can get them out of isolation. Okay. Just to quickly run through Oncoscopy, this is a bronchoscope. Okay. The newer bronchoscopes look a little fancier, but they can go through the nose or they can go through the mouth. Okay. And then you have to get to the trachea, go through the vocal cords. And when you get to the trachea, that's takes you to the lower respiratory tree. So when you're in the trachea, you go down the trachea and then you hit what's called the carina. This is the carina. This is where this is a nice view. I saw this view probably 5,000 times. But this is a view that you want to see. It tells you you're right smack in the middle of the trachea, and you've got easy access to both bronchial trees. This is called the carina. I think carina is either a Greek or a Latin word meaning blade. The carina of a ship, like that pointy thing, you know, in the front of a ship. But so that would be right here. The carina would be right here. And then you could either go through the right and then examine the right, and then go through the left and examine the left. Okay. This guy has something right at the carina, right here.
Do you think it's like slightly detached?
No.
Oh.
No. I don't
What usually causes lesions at the carina?
Cancer.
Um,
Although this doesn't really look like cancer. This is kind of smooth, and I don't know if it's some type of a cyst, but usually cancer. So there's a working channel in this bronchoscope, and then you can put through instruments, and you can lavage, you can biopsy, you can do all kinds of things. Okay. These are some of the why we would do bronchoscopy. If someone had a lump in their lung, we call a mass or a nodule. You know, we want to know what it was. Is it cancer? Is it an infection? If they're coughing up blood, hemoptysis means coughing up of blood. There's actually a heavy metal group name called hemoptysis. But it's coughing up of blood. So if you went into some, you know, a 70-year-old person comes in, who's a prior smoker, coughing up blood, you want to look down and see if you can find where the blood's coming from and what the blood's coming from. Okay. A wheeze you usually see with asthma or COPD, but if it's on one side, then you would worry about a tumor or a foreign body blocking one bronchial tree. So you would look. Atelectasis means collapse of a lung. So you would want to see, is there something blocking the airway or any of these airways? If you block the airway completely, then everything distal is going to collapse. Once the air resorbs, everything's going to collapse. That's called atelectasis, is collapsed lung. Okay. And there's a bunch of other things like unresolved pneumonia. If a regular pneumonia should resolve in 6 to 8 weeks. If someone comes back 3 months later and their x-ray looks the same, then it's probably not pneumonia. So you better take a look and see what's going on.
How do you reverse atelectasis?
Well, if it's mucus, if it's a mucus plug, if you remove the mucus, then you allow air to get in and then reinflate the lung. Okay. If it's a tumor, then you're going to have to get the tumor, you know, out of the lung in some way, or reduce the tumor size so you can get air through. Okay.
Okay, thank you.
Yeah, but we have people, especially our hospital was a block away from a long-term facility, a rehab facility, and there were a lot of people that they were on like a paraplegic and quadriplegic, and they had a lot of airway problems. We were always dealing with mucus in their lungs because they didn't have the muscle strength to cough up the mucus. This was some of the things you can do with bronchoscopy. You can just look, or you can biopsy, or you can brush, or you can wash, or you can lavage. There's a lot of things with it. This is called EBUS, endobronchial ultrasound. You can actually get to the lymph nodes in the lung. Any questions, guys?
How does it get to the lymph nodes? Do you just keep going down?
Because you see it on ultrasound. In other words, the lymph nodes are not within the lung.
Mm-hmm.
They're outside, they're surrounding. But you're down there with the scope, and then there's an ultrasound probe at the end of the scope. So you're able to see the nodes.
Oh.
Okay. And then you have a device, then you can, let's just go back here. Let's say there's a big nodal group right here. They call it subcarinal, or it's called stations. All of these nodes have station numbers. This is called station 7. Okay, so let's say there's a really big lymph node under here. So you would, I'm sorry, not under here, under here, here. All right. So you would just position your bronchoscope here, and then visualize the lymph nodes under ultrasound, and then you have an instrument that you would put through and right into the lymph nodes.
Oh, wow.
Okay. Okay. So again, it's a low risk procedure, but in high risk patients, the risk goes up. In patients that are on the, have low blood pressure, have low oxygen, or on the ventilator, it can be a higher risk because they don't do well with anesthesia and low oxygen and bleeding. So you have to be quite skilled in what you're doing. Okay. Just this is tuberculosis assessment, tuberculosis skin test. This is known as the PPD. Okay, it's actually the oldest test we use in medicine. It's over 100 years old.
That's pretty interesting.
And this is a skin test. It must be read at between 48 and 72 hours, which is one of the problems, because if the patient doesn't come back, you can't read the skin test. It's the same thing with the vaccine. They got to get 2 shots. If they don't get the second shot, if they don't come back for the second shot, you wasted the first shot.
Yeah.
And then you have to measure the area that you injected on the arm. Okay. And I'll show you a picture. A positive skin test documents TB exposure, but not active disease. So if you develop TB, as a youth in India, and now you're 40 years old and live in the U.S. and you have a positive PPD, well, you may have picked it up in a country where TB is endemic. So it tells you you've been exposed, but you don't have active disease. If you're very, very sick, you may have a false negative because your lymphocytes, or let's say your lymphocytes, are otherwise engaged. Okay.
No.
There's something called a Tine Test, which is a multi-puncture technique, which is used for mass screening and not as sensitive. So, anybody ever have this? Everybody ever have a PPD?
Yeah. Yeah, I've had it before.
All right, this is how it's put on. Okay. So it takes a little bit of skill to be able to get it intradermally, make a wheel, okay, and then leave it alone, and then in 24 to 48 hours, come back and measure it. You're not measuring the erythema. Erythema is redness. That's a big mistake a lot of people make. You're measuring the induration, which is the hardness. Okay. So, and you can see this patient looks like they have 10 millimeters of induration, while they have over 20 millimeters of erythema. Anybody ever have a Tine test? This is for mass screening. This is a 4-prong device, and you kind of just punch the patient's arm with it, and again, read it in 24 to 48 hours. Not as sensitive as the PPD. Okay. And then you see how many millimeters of induration you have. And if you have, so we consider the PPD positive at 5 if you're kind of a sick patient. If you have AIDS, if you're a transplant, if you're on immunosuppression, if you're on high dose steroids, okay? If you have chronic kidney disease. So if you're a chronically ill patient then greater than 5 is considered positive, okay? Also, if you're in close contact with a TB patient. Greater than 10, you're considered positive if you were born in a country with a high prevalence of TB, or if you come from if you're homeless, an IV drug user, resident of a long-term care facility, in prison, or all of us, medical staff. All of you guys that are going to be medical students or work in medicine in any way, if your PPD is greater than 10, then you're considered positive, okay? Why is that? Why do you think that is?
Oh, I just had a question.
Go ahead, go ahead.
So if there's a 9 millimeter induration, is the test just redone, I guess, just to minimize any chance of inaccuracies?
Yeah, you could do that. It depends on what your suspicion is. Okay. All right. So if the patient's in prison and the guy in the next cell had TB and it's 9 millimeters, you know, call it positive. Okay.
Okay.
All right. You're going to be asked, Greg, you're going to be asked in medicine to make a lot of judgment calls. And I'll tell you again, it ain't science. Most of what we do, unless you become, you know, an MD, PhD and work with Bent's research, at least half of what we do is just taking some scientific fragments and making a clinical judgment.
Right.
So,
yeah,
so
that makes sense.
Yeah. You know, if it was a kid in a suburban New Jersey school who never left, you know, who never left their suburban neighborhood, you know, and had no exposure to anybody or have done anything, then he shouldn't get and it was 9, you know, you probably wouldn't treat him, but that person shouldn't get a PPD anyway because he's such a low risk. Okay.
Yeah. Okay.
So that means that the general population, okay, civilians, you have to have 15 or over. All right. Now, if you talk to an old doc, he may tell you 10 because as I was, you know, growing up through the system, it used to be 10. Anything above 10 was positive, but now it's 15. And 10 is, you know, 10 is this group. Okay.
Interesting.
But there are a lot of docs that were born in foreign countries. So there's a lot of haggling over PPDs in residency programs. Okay. You can also do a blood test. I prefer to do the blood test because the problem with the PPD is that you have to put it on accurately. You have to read it correctly, and the person has to come back in 48 hours or 72 hours to have it read. So there's a lot of chance of having, you know, something breaking down. So the quantiferon test is a blood test. It's called TB Spot or TB Gold. Is a test that aids in the detection of TB exposure, just like the skin test. The white blood cells of exposed individuals release gamma interferon and when mixed with TB antigens, produce a measurable response, okay? So you should get a positive or a negative on this. Unfortunately, there are some intermediates and it's hard to know what to do with this. Now, why is this better than, this has replaced the PPD skin test in many centers because its sensitivity is about the same as the skin test, but you know, you don't have to go through putting it on, reading it, you know, and having the patient come back. And it's also, you know, it's much less subjective because you're not measuring it or reading it. You're getting a blood test result. Okay, so it's especially helpful in screening individuals who have had BCG as children. So again, in the hospital, we had a lot of residents who were born in India, Pakistan, Africa. And they all had BCG, which is the TB vaccine as children, which doesn't keep you from getting TB, but it keeps you from getting TB meningitis and miliary TB as a child. And so there was always a question of whether their skin test was due to the BCG that they had as children. Okay, so you can get rid of that by doing the blood test, it's called the quantiferon assay.
Interesting.
Okay. What time it is? I don't know. I don't have a clock with me.
It's 4 o'clock.
It's 4 o'clock. Do you guys want to quit or go do one more?
I'm fine with keep going.
Yeah, it's up to you, Dr. Promisloff.
Okay. All right. You're going to hang on. Okay. These are lung scans, what they call ventilation VQ scans, we call them. Okay. And they're mainly to diagnose pulmonary emboli. Okay. We call them PEs, pulmonary emboli. Again, if you work or you shadow in an emergency room, okay, you're going to look for a lot of PEs because that's one of the acute things that you have to pick up early, okay? Because we send somebody home with a PE, a PE is a clot in the lung. A pulmonary embolism is a clot in the lung. It usually starts in the leg and ends up in the lung and could give you chest pain, shortness of breath, or could kill you. You know, it can be anything from a little bit of discomfort to kill you. And you basically put you look at the ventilation of the lung through a radioactive gas, and you look at the perfusion of the lung, which is the blood flow, by injecting usually radio-labeled macro-aggregated albumin. So you're getting, so this is what you're getting. You're getting this is all the little radioactive particles in the blood vessels. So this is perfusion, and this is in the airways. This is ventilation. So this person here has normal perfusion and normal ventilation. So there's really nothing wrong with their lungs. Okay.
That's really cool.
Yeah. This is done in nuclear medicine. So this is not done in the emergency room. And to have it done in the emergency room, you have to have a technician come in the middle of the night. And you're more than likely going to get a CAT scan rather than a VQ scan for PE.
Besides, I guess, suspicion of pulmonary emboli, when would a VQ scan be ordered?
Well, that's Greg, that's the only practical reason to do a lung scan. Now, there are a couple other ways to do it. One is if somebody has lung cancer and you want to know how much viable lung they're going to lose when they take out the tumor, okay, you can use these scans. They're called quantitative scans. So if you're going to take out the right upper lobe, you can quantitate how much of their ventilation and perfusion they'd be losing. So that's another reason to do it. Okay. You can also look at airway, how well the airways look with the ventilation scans. Okay. But practically, the only way the 95% of the time they're used for clots, for PEs.
Okay.
Okay. All right. And they don't give you any other diagnosis. So here's a good example, if you want to look at this, of somebody who has fairly uniform ventilation, okay? But look at all these holes they have on perfusion. We call these segmental. These are segments, big chunks out of their blood vessels. So this is perfusion, but the ventilation, you see, is fairly good. So this is called the ventilation perfusion mismatch, okay? There's multiple areas. If it was just one area, it wouldn't be so great, but there's multiple areas of mismatch. So this would be read as high probability for pulmonary embolism. So these scans are really read as either high, intermediate, or low probability, okay? And they don't help you much with other diseases. For example, if somebody had pneumonia and you thought they had a pulmonary angiogram, pulmonary embolism, it wouldn't tell you they had pneumonia. A CAT scan with dye, a CT angiogram, would tell you whether they had a PE, but would also tell you whether they had pneumonia or not, okay? So in some situations, this is better, but there's more to it, okay? So again, it's all probability. If you call it low probability, then they probably have around less than a 5% chance of having a clot. If you call it high probability, more than 85% chance of having a clot. Why do this instead of a CAT scan with dye? Because maybe the patient has bad kidneys, and if you give them dye, they're going to go into kidney failure. Okay, that's a major reason. Or maybe it's a little old person from a nursing home who doesn't have any veins. You can't get a big IV line in to get the dye in, so that would be another reason. But I would say that, certainly in an emergency room setting, 95% of the time they're going to do a CAT scan, a CT scan, okay? In other settings, they may do a lung scan, a VQ scan.
So I guess with the probabilities, how does the treatment algorithm differ if someone has a low probability versus, I guess, medium probability?
Yeah, so there's a study, Greg, called you may want to look it up, called the PIOPED study.
PIOPED?
PIOPED, yeah, Prospective Investigation of Pulmonary Embolism Detection. I think that's what it stands for, PIOPED, okay? And they go through how they came up with the algorithms. But for example, let's say you have a low probability scan, but as a clinician, there's a high clinical suspicion. You think as a clinician that given the story and given everything else, there's nothing in the world this patient could have but a pulmonary embolism. Okay, but their VQ scan is low probability, then they're going to have like a 30% probability of a PE. Okay, so then you need something else. You have to put dye in that patient.
Okay. Yeah, I'll definitely check out the study. I added it to my
but it's what's that theorem? The Bainsian theorem, that the chance of a test being positive is based on the preclinical suspicion of the test, the preclinical probability. So I think that's a Bainsian theorem. But it means a lot. It's a lot of things, a lot of tests in medicine. It's your pre-test probability is extremely important to what the test is. Okay. Same thing with high probability. If you have a high clinical suspicion and a high probability scan, they got a PE. But if they have a high clinical suspicion, if you have a high probability scan and a low clinical suspicion, then there's a 20% chance they may not have a PE, a pulmonary embolism. Okay. Just quickly, a thoracentesis is getting fluid out of the patient's pleural space. This is a big pleural. So, Greg, this could be a hemothorax. You see this?
Yeah. Okay.
See this huge? So, what is this? This is fluid in the lung called a hydrothorax. Okay. So it could be clear fluid. It could be pus. It could be blood. The only reason, the way you know, is to stick a needle in like this. Okay. And Dr. Seema was talking about doing that with ultrasound. Okay, stick a needle in, collect the fluid, and the fluid collects in the bottle. Okay, and then you send it off to the lab for all this stuff. Okay, is it an infection? It could be. Is it a bacterial infection? Is it tuberculosis? Is it thin watery fluid that you would get with congestive heart failure? Is it inflammatory fluid like you would get with a connective tissue disease, like with lupus? So all of that stuff. And when you get into medical school, you learn about Light's criteria for transudate versus exudate. A transudate is a watery fluid that's associated with heart failure and cirrhosis and kidney failure, while an exudate is a proteinaceous fluid, which is associated with cancer and infection and inflammation. All right, guys, I'm going to stop. You have any questions?
Why does cancer cause it to be more proteinaceous?
Because it invades the tissue, and it invades the blood vessels and allows protein to leak out.
Oh, okay.
Same thing with infection. Okay.